Hello, everybody. Thank you for joining today's webinar. If you've been following this series for the last several months, you know we do a lot of very focused sessions on specific organs or systems within the body and how Prenuvo screening is really relevant for those topics. Today, I'm excited to introduce today's topic to actually discuss a little bit more holistically around cancer as the topic. So really whole body MRI for preventative cancer screening. Today, the session is hosted by myself. I'm Eric Chafe. I'm VP of Sales here at Prenuvo. And we also have the awesome Dr. Vikash Modi, our Senior Medical Director of Preventative Medicine, who will be running the bulk of the show today. So before we jump into the topic, let me just, again, a little high level, let's introduce you all to Prenuvo. I'm sure a lot of you might already be working with us, very familiar. Some of you might be brand new to hearing a little bit about Prenuvo. So really, who are we? As an overview, we are a dedicated whole body MRI imaging practice. Today, we have 17 clinics across North America, and that number is steadily increasing. We'll be opening 2 more locations next month and probably another 12 or so more this year. So it's really great to see the growth. Our focus is on proactive whole body MRI imaging. We're the world's first practice focused solely on this, and our focus remains on the routine longitudinal MRI imaging. This is our expertise, right? We currently have a team of over 80 radiologists on staff who conduct our reads, who work with us, provide that feedback, help us grow. And to date, we have done over 120,000 whole body imaging. So this really is our expertise. And we're proud to say, honestly, that our team has played a major role in the technical advancement of MRI application for general whole body imaging. A little bit around our growth and impact. As I mentioned, we've scaled up quite a bit. We're seeing a lot more patients today than even we were just 2, 3, 4 years ago. And we've been doing this, though, for over 15 years. So this is really our expertise. And when it comes to the impact, a key focus for us is working with providers such as yourselves to really help drive this change in the healthcare system to be more proactive about our health, to catch things a lot earlier when often lifestyle modifications can be the solution. And so that's why we love working with you all and connecting with you all and really partnering to drive that change. I'll share just a look at one of our facilities because I think this is a pretty important piece. I think a lot of people often might consider or think about an imaging facility as something that feels a bit more cold and clinical. One key strength of ours is we really want to be an extension of your practice. We understand that the patient experience, patient comfort are extremely important, elements of our business model. And one strength of ours really is that we own our facilities, right? And we only conduct whole body imaging in these facilities. So every person you deal with, from support, from the person on the phone, to the person at the front desk, to even the radiologist that is producing the report, is a Prenuvo employee. And this really allows us to continue to optimize every step of that patient journey. And here's a look of our New York clinic. As you can see, we put a big emphasis on creating that warm, welcoming environment that really helps reduce any sense of anxiety that one might have because they undergo one of our exams. And so our goal is really to make disease a lot less scary. The big piece of this is catching it early, right? Early detection, much earlier than the status quo, which we'll probably talk a little bit more about today as it pertains to cancer. Another key piece of this, again, is making that experience much more concierge like you and much more relaxing for the patients. Here's a look at the actual magnet. So we use a wide bore, it's an open bore magnet, memory foam mattresses. Patients can actually view, so you can see one of the images here on the screen, you're actually looking through the bore at a TV screen. And so patients, as they're laying there, will look up at a mirror that we've fastened to the coil, and they can actually see Netflix or a movie. They can listen to Spotify, a podcast. I'll hand it over so we can get into the meat and potatoes of the presentation. But as a wrap up, we really focus on that patient experience, and the experience actually in Magnet is one of the things we're quite proud of. Claustrophobia is often a data point that many folks look at, and proud to say that across all our facilities is less than 1%, which is quite a bit better than you'll see in the kind of current status quo across imaging facilities. Back over to Vikash.
Thanks again for everyone hanging in there with us. I'm really excited. I was very excited to give this webinar, and I've been saving it up because of the really the context here, which is such an incredible thing that through our time at Prenuvo and whole body MRIs, one of the fundamental things that this type of study was designed for was to help us detect cancer. When we look at the history of whole body MRIs, this is one of the things, if not the thing, that it was initially intended to do. And now here we are, it's National Cancer Prevention Month in 2025, and we have this really interesting opportunity to focus on something that we've touched on in our previous webinars, that the whole body MRI can evaluate livers and brains and pancreas. And in each one of those presentations, we talk about the capabilities and the limitations of whole body MRI when it comes to detecting cancers of those organs. Today, we're going to just focus on that piece. It's not a snippet, it's the entire meat and the potatoes. I want to be really clear once again, as I always am about this, that we at Prenuvo very much support the USPSTF guidelines for standards of care around the types of cancers that have those proven evidence-based guidelines, that we are adjunctive, that we are another layer of protection and safety that we do not replace, but we enhance. And I want every patient, I want every provider to really fundamentally understand that is our perspective as a company, and that is my perspective as a provider, that I'm not going to replace the things that have incredible data behind them in lieu of a Prenuvo or a whole body MRI, but I am going to make sure that my patients have access to this test because of how incredible it is at enhancing those detections. We're also going to talk a little bit about, how to tackle a number of those cancers, and some of these things that don't have any guidelines whatsoever is really where Prenuvo lives. The whole body MRI really fits into this space that is not yet defined when it comes to cancer screening and detection. And there's this tacit responsibility within the patient-provider relationship to observe for these signs and symptoms of potential cancers and to use every tool that we have at our availability. Let's first, of course, start with the epidemiology, the numbers. The current state of cancer prevalence and incidence in America is something that is a constant topic of conversation in the news, in medical journals. At most recent publication, about 2 million new cancer cases are expected to be diagnosed in this year in the US alone. Broken down, we estimate about 618,000 people will die in just this year. That's 1,700 people a day. And that is, by all, stretches of the imagination, an astronomical number that I don't think we really are grappling with when we think of the existential crisis that cancer is presenting us as a country. The number is even more startling when you consider that 88% of cancer victims are over 50. So we have this aging population now. Patients over 50, patients over 65, retirement, looking forward to the last couple of stages of their lives and their careers and their family. And then they're struck with this awful diagnosis of cancer. And couldn't we see it coming? Didn't we have a way to protect them with all this technology and all this money that we throw at healthcare? To me, one of the most personal and shocking statistics is that cancer is the still leading disease-related cause of death for both children under age of 14 and adolescents. Cancer.org indicates that nearly 10,000 children are going to be diagnosed this year. 1,000 are going to pass away from cancer this year, and these are really numbers that we can't live with this. This is not something that we are going to wish away, that we need to start to get more innovative with our treatments and with our screening and protection. Prevention is going to be fundamentally the next stage of American healthcare. So there it is, primary prevention, regular robust screening, early stage detection, more innovative treatments. These are what our entire healthcare system is now pushing towards with Medicine 3.0. A reminder of the current indicators from the CDC are that 1 in 2 people are going to develop cancer in their lifetime, and the rates of disease in younger folks are on the rise. Our USPSTF guidelines are only covering 4 organ systems. Routinely, that's the colorectal, prostate, breast, and cervical diseases. And then we have that optional 5th system with lung cancer screening, but you have to kind of hit the qualifications for that to even qualify per the USPSTF and the insurance guidelines. As of 2022, only 14% of active cancer cases are being detected by those standard guidelines. That means 86% of other cancers are undetected and have no routine screening recommendations around detecting them, that we find them by chance, by incidence, We find them because the symptoms are already active, which is most likely an indicator that the disease is in later stage progression. The last unfortunate statistic on this slide is that based on current available screening tests, as much as 45% of diagnosed cancers occur at those late stages. That's 3 or 4. And those, of course, have a far more dire prognosis than the ones that we find in stages 1 and 2. That's the problem. We all know the problem, but let's move on now from the progression of cancer and shift towards a focus on proactive detection and prevention. Consider these facts from the American Cancer Society. 45% of cancer cases are potentially preventable. There's been, again, huge amounts of news over the last couple of months regarding the potential impact of lifestyle modifications around alcohol consumption, tobacco consumption we've known for years now, but now the obesity rates in this country and our dietary habits are now contributing to what we see are lifestyle modification, preventable methods for preventing cancer. And when detected early, these average 5-year survival rates for most cancers is over 80%. That there are now people living with chronic cancer or living in remission well into their later years, because when we do catch them early, the trajectory changes incredibly well. So let's again reframe whole body MRI, a quick debrief on what the technology is. It's by no means new. Whole body MRI has been around since the early 2010s as an available technology, but the precision and the reporting of these findings have evolved and are emerging as a technique now that we can serve patients in a way that we never thought possible. Prenuvo, in particular, founded in 2018, has worked with hardware manufacturers, software developers, and have refined this process that once used to take 2 hours to do and a number of radiologists to read one report, now in under an hour and a single radiologist is able to read these. And these times and these numbers are just enhancing now with the advent of the digital revolution with AI, with hardware and software technologies evolving every day. The scan time is going to get shorter and shorter. And the big piece of all this is that these things are going to make it cheaper. And when we talk about screening tests, we have to acknowledge the impact of the economics that, we can all be screened with a full body PET scan every year, but right now the cost is incredibly prohibitive. And that's why it's just not done. Now, and PET scan have their own issues with contrast and our IV radiation. Whole body MRI is a state-of-the-art method. It's rapid. There is no exposure to ionizing radiation or heavy metals from IV contrast. And the cost is now achieving a break point where it becomes a reasonable expense for a lot of people. For a lot of people, it's still not. And that is where we hope that we're going to partner with institutions, we're going to partner with providers and healthcare providers as well as insurance providers. And we're going to figure out how to make this democratic. So let's again briefly look at the sequences that are key to a whole body MRI. By not having IV contrast, we are still compensating for that by using soft tissue contrast capabilities intrinsic with multi-parametric techniques. The secret sauce for Prenuvo is something called diffusion weighted imaging, or DWI. And that's what gives Prenuvo the ability to maintain a high level of sensitivity and specificity for screening without the invasiveness or risk of most contrast enhanced non-MRI techniques. So when you think about why is Prenuvo, why this 1.5 Tesla magnet is apparently so good for detecting cancers, this is why, because of this particular type of sequence, plus the hardware and the software. And I'd be remiss not to mention the people who are managing your results and helping you to understand what to do with these images. As we've alluded to, the whole body MRI has developed into this technique with really interesting implications for cancer screening. So in a 2023 clinical study called the Polaris clinical study, this is run by Prenuvo. We've done our own research in 2023. Whole body MRI in our Vancouver site led to biopsies in about 4% of total scan patients. So we'll say out of 100 patients, 4 of them were recommended to get a biopsy. We actually scanned about 1,000 people in that trial. So we can say about 40 of those patients. And in that cohort, we were able to achieve a 56% positive biopsy rate. So this is a slide that I think a lot of providers and even a lot of patients are going to take a lot of interest in, that we are now publishing. We have published and we are now discussing widely that we achieved a 56% positive biopsy rate. Now, that is across all cancers. We didn't get granular here and start breaking it down to different systems because the cohort was so small. But that is yet to come because I think that it's really important for providers to reframe their questions. Well, what's the sensitivity and specificity of Prenuvo is it sensitive or specific for brain, for breast, for pancreatic, for spleen? Because of how MRI works and our sequences, it's not going to be uniform. It can't be uniform. That the ability to penetrate and detect in the brain is different from the ability to penetrate in the breast and the stomach and the pancreas. And so that is why when you are asking yourself how sensitive or specific is this test, reframe the question and ask for which organ system or for which type of disease. That is data that you deserve, and that is data that we are trying to get to you. Compare that 56% positive biopsy rate, by the way, with 64% of cancers detected in early stage 1 or 2, and that's much higher than the 55% through standard USPSTF guidelines. So what's most remarkable to me here is that 68% of the cancers detected through Prenuvo had no standard screening test whatsoever. To me, the next most exciting thing that Prenuvo is now doing is launching the Hercules study. This is a significant expansion of what we did in Vancouver in 2023 with our 1,000 patients. We've now launched in our Boston clinic. It's only in Boston for the moment. The Hercules clinical study, which is going to start gathering sensitivity and specificity data for various diseases, various types of cancers, as well as true positive biopsy rates and rates of disease detection with management outcomes. So cancer and non-cancer alike. And our cohort is going to be 100,000 patients over the next 10 years. We are doing a wide study. We're doing it longitudinally over 10 years. This is going to be, alongside performance and outcomes data, this is going to be the largest, most reliable, and reproducible data set on whole body MRIs to date. And this is, our hope is to make a massive impact in literature, in evidence-based guideline consideration. We want to review this with the USPSTF and talk about how our technology can change the cancer trajectory and impact the cost of life, cost of healthcare alike. So please stay tuned. HerculesStudy.org is where you can follow along with us. When we have data to publish, we will publish it there, and there'll be press releases galore, I'm sure. But this is a really, really exciting time to be looking at whole body MRI. Another really important piece of looking at whole body MRI for cancer prevention is thinking about how do we rate these systems. And this is a slide that I like to include in as many decks as I do, as many presentations as I give, because this kind of gives you the language to talk about risk of cancer. It's called the OncoRad system. This is something that we at Prenuvo helped pioneer. It is a system of describing oncologically relevant findings with a reporting in a data system. So if you're familiar with BI-RADS for breast cancer reporting or PI-RADS for prostate cancer, OncoRADS refers to whole body risk of cancer. And this is helping our radiologists, our preventive medicine consultants, our colleagues outside of our practice interpret and respond to the significance of our findings in a really structured and reliable manner. So again, when you talk about, well, they pick up cancer or did they pick up something that was high risk? This is what we're asking. What was the OncoRADS? Was it an OncoRADS 1 or was it OncoRADS 5? This is going to be the language of discussing whole body MRI. I love also to put this slide in every conversation I have about preventative medicine because it is the still gold standard. The USPSTF is our guiding light. They are reminding patients not to skip or delay these standard recommended tests. So even in conjunction, if you've already done a Prenuvo scan, you should not be skipping your mammograms. You should not be skipping your colonoscopies. And there's an important piece there, which is that the Prenuvo whole body MRI, as excellent as it is as a sort of a whole body home inspection or a metal detector on the beach, it is not going to dig as deep as those dedicated tests can. And so we want to make sure those cancers that have an answer are being tested in their fullest capacity. And finally, before I jump into each individual cancer type, I want to make sure that our providers and patients who may be watching this understand something, that whole body MRI scans are currently most successful at providing insight of potential risk when there's an absence of active symptoms or disease. That is the essence of screening. Symptoms and disease change pre-test probabilities. And for that reason, Prenuvo has decided that patients who have a history of active disease, whether it's cancer or a known ACL tear, should be getting dedicated scans to follow those things. A screening test is not the same as a diagnostic test, and that is Prenuvo in a nutshell. We are a screening test, not a diagnostic test. So when we do have patients who still want to pursue a whole body MRI and are able to pursue a surveillance of their other known diseases through outside methods, we offer this provider-assisted pathway. It's a bit cumbersome in that it is a form for patients to fill out to sort of give us insight into their disease, their active condition that they're treating, how they're treating it, when it was diagnosed, what was the last set of imaging like. This gives our radiologists and our clinical team a significant insight into what we should be really focusing on, if we need to take a small lump in the bone of the thoracic spine seriously as a possible metastasis of prostate cancer, or if we can, really trust our gut, which says it looks more like hemangioma. Because what we don't want to do is overdiagnose. What we don't want to do is undervalue things that we're seeing on the scan. Giving us context, as much history as possible, is always the best method of getting the best results and best outcome. Okay, so now we can move into some details about what it is that whole body MRI can detect with regard to potential malignancies. While the list of malignancies that we're able to detect through whole body MRI is extensive, we're going to focus on just a select few types today and some example cases to illustrate the application of this incredible technology. We'll also discuss the challenges that still exist with whole body MRI with regard to some of these types of tissue systems. And that's why whole body MRI is not yet considered the standard of care for cancer surveillance, staging, or replacement of the USPSTF guidelines. So first up is breast. A really tough subject for every patient involved, for every clinician involved. It is such a dreaded condition, and yet it is something that the American healthcare system has come a long way in tackling. So again, quickly by the numbers, breast disease is not rare. About 60 to 90% of suspected lesions will be benign fibrocystic disease is the good news. But over 91% of solid breast masses in women, those are something called fibroadenomas. Here's the big number. 1 in 3 cancers in women are breast cancer. And routine breast screening, though through validated methods, is one of the most important ways we can protect our at-risk population. Thankfully, due to diligent screening programs, public education, provider support, we now have achieved a 5-year survival rate for women diagnosed at stage 1 at nearly 100%. The flip side of that number is that for patients who do not engage with their routine screenings, there is a dismal 25% 5-year survival when those diagnoses are at stage 4. So the take-home lesson here is get it diagnosed early. If you suspect something, do something, and make sure that you do your follow-up scans so you can track progression over time. So let's look at the differences between a standard diagnostic breast MRI and a whole body MRI as it regards breast disease or breast screening. The standard of care after mammogram and ultrasound is a diagnostic breast MRI, and that modality is impractical, but that modality is impractical in the screening world due to the cumbersome nature of the test, which involves IV gadolinium, inverting positioning of the patient, and using dedicated breast coils. Those 3 aspects, the IV contrast, the inverted position, the dedicated breast coils, are the reasons that it doesn't typically fit into a screening process because of how cumbersome, time-consuming, and invasive it is to the patient. And so that is why that is not the sequence that is used at Prenuvo. Prenuvo avoids IV contrast. They allow the patient to remain prone, and they don't use these additional coils. And that allows us to achieve a faster but less precise screening technique. We have found, however, that when coupled with standard mammography and ultrasound, that our sequence can detect hypercellular lesions even more thoroughly than those tests alone. We can contribute to initial staging and subsequent clinical responses, and we can identify post-therapeutic changes and complications much more effectively than those standalone tests can. So we are very much contributory to managing and detecting breast cancers, but we are not a replacement. We are not a standalone for breast cancers. So I want to really make sure that that is pretty clear here. We have not been proven as sensitive or specific enough to be included in routine screening for breast disease. And we don't endorse whole body MRI for surveillance, follow-up, or dedicated breast disease detection as a standalone option, rather as an adjunctive test to mammography and ultrasound. So I'm going to keep kind of hitting that point over and over again when it comes to breast cancer. Now, all that being said, let's look at a really terrific case that came out of our archives. This case is a 54-year-old woman who was experiencing no symptoms at the time of her scan, but was found to have a left-sided hyperintense lesion, which you can see the small arrow there in the top of the screen on the right, that was described as a suspicious lesion. That 2 centimeter mass went on to be biopsied and was confirmed as an estrogen positive, progesterone positive, HER2 negative intraductal carcinoma. And that had not been detected by the patient's prior 2D mammogram. So I want to break that down for just a moment. The patient had a simple 2D mammogram. The new standard of care is now arriving at 3D mammogram. And if there is suspicion of a lesion, a palpable mass, or an abnormality on the mammogram, you will get an ultrasound. This patient's mass was not detected on the mammogram, and so no ultrasound was done. Instead, by coming to Prenuvo, we were the safety net. We happened to catch what the 2D mammogram didn't. We like to think that if that patient had a 3D mammogram and then a subsequent ultrasound, that they would have also caught the lesion. But we're so happy that we were able to help this patient's case arrive at a very early stage diagnosis. So we move from one of our weaker things to one of our stronger things, which is prostate cancer detection. Again, some quick numbers here. An estimated 1.6 million cases of prostate cancer are going to be diagnosed this year, and about 366,000 deaths will occur from prostate cancer this year in the United States alone. About 11% of males are diagnosed with prostate cancer over the course of their lifetime, and the incidence generally rises with age, as we know, in clinical settings. Thankfully, due to more early stage detection, the adoption of screening using the prostate-specific antigen tests and digital rectal examinations, and aggressive targeted treatments, America has achieved a 5-year survival rate of over 98% for prostate cancer. It has now become, in many, many cases, a chronic condition that is manageable rather than a catastrophic fatal disease in cases that are caught early. One of the arguments is that perhaps prostate cancer is overdiagnosed in that case. When you think about the long-term survivability of prostate cancer, is it something that we even should be diagnosing and treating in the first place? Our position is, of course, yes. You want to know what diagnosis you have, and that gives you all the options on the table to manage that disease. The consideration would be that, purely based off of a PSA plus a template biopsy protocol, the real implications here are that we are potentially overdiagnosing or overtreating, and patients are resulting in lifelong complications from those biopsies and radiation and surgery that they may need not have if there was serial imaging involved. So Prenuvo, we posit that perhaps a more suitable way for managing some of these early stage prostate cancers, these non-aggressive diseases, would be serial imaging plus PSA, but that is something that is not yet formalized. But we like to also think that whole body MRI can contribute to the science of that theory, and that is something that we hope to achieve over the next few years with Hercules. All that being said, of course, we're going to see things on a Prenuvo scan. For instance, this patient, a 61-year-old male, had a PSA of 3.72 on his most recent checkup. We did the Prenuvo scan and decided that this patient had a generally dense prostate volume of 25 milliliters, so an elevated prostate density. And this patient also had signs of what we'll say ECE, that's extracorporeal excursion there, and that is given him a diagnosis of PIRADS 5 lesion. So again, these advanced sequences detailed the discovery of not just primary prostatic lesions, but also potential metastasis. Luckily, this patient had none by doing a whole body survey. This patient's outcome was excellent. That based off the relatively low PSA, absence of metastasis, the patient was fortunate enough to have targeted photon beam therapy for his prostate cancer and spared from significant surgery and broad range radiation, which may have otherwise caused some significant collateral damage. So this patient was very grateful for our detection and early intervention despite the PIRADS 5 lesion. Moving on, we're going to touch on lung cancer. Lung cancer is another difficult subject for whole body MRI because, of course, it is not a dedicated modality per the USPSTF and per ourselves. So lung cancer screening is traditionally offered through low-dose CT of the chest, which is, the standard of care for multiple reasons, not the least of which being that CT, computed tomography, is just better than a non-contrast MRI at detecting lesions in the lung. So that is why it is still the standard of care. Here's the rub. Screening in America is estimated at less than 6% of eligible patients at this present time. That's compared to PSA prostate cancer screening at 70% and breast cancer screening, which is at 80%. So we are drastically underutilizing the resources to screen for lung cancer. And that needs to be an argument in every primary care clinic. If a patient qualifies based off of their history of smoking or symptoms, then we need to make sure that they're getting access to that low-dose CT. for multiple reasons, whether that's the radiation of a CT scan, the expense of that test to the insurance company or to the patient. It's just not being heavily adopted. Just to review the criteria, low-dose CT is for ages 50 to 80 years old who have a 20-pack year history of smoking and currently or have quit within the past 15 years. Which when rates of cancer incidence have historically been observed to drop, by the way, is after the 15-year mark, you've almost reduced your risk back to the population risk if you haven't had cancer yet. So due to the multiple limitations around accessing care through CT and PET scans, screening for lung disease is generally considered an underperforming project, and it's going to require innovation and evolution of guidelines in order for us to really improve these outcomes. So think about the next slide I'm showing here, where we talk about advancements in MRI techniques, that we've now enabled greater than 90% detection for non-solid and part-solid lesions ranging 4 to 29 millimeters. That's a really, really important criteria that we identify, is that the low-dose CT and lung cancer screening program was actually equivalent to MRI as long as those nodules were 4 millimeters or greater. That means that for 3 millimeters and smaller, you're still best to rely on CT lung screenings. But there's now a large segment of lung nodules and lung lesions that we can start thinking about using MRI to serially follow and start diagnosing these conditions. Diffusion weighted MRI, you remember I talked about DWI, the bread and butter sequence for Prenuvo, is considered that most useful technique. And a meta-analysis actually showed that sensitivity and specificity reached 83% and 80% respectively in the differentiation between malignant and benign lesions when we use diffusion-weighted sequences. So the diagnostic odds ratio of 50 for DW-MRI is superior to that of PET and CT scans, especially when we have solitary pulmonary nodules greater than 3 millimeters. So this is not to say that we're going to use a whole body MRI, non-contrast Prenuvo scan to replace low-dose CT. We're not there. What we can say is that we can now be another option, especially if you already have a lesion greater than 3 millimeters, another avenue to help surveillance without radiation, without contrast, some of these nodules to see if they're evolving and to jump on them incredibly early. But we have to improve that 6% scan rate. It's inexcusable at this point. Here is a case study that kind of demonstrates the point. Let me see if I can play this video here. What we're looking at here is a left upper lobe opacity, a nodule that was detected on a whole body MRI scan. Now, the official report describes this left upper lobe thick wall cavitary mass measuring 3.7 by 3 centimeters as a highly concerning for neoplasm in OncoRADS5 likely malignant finding. The mass abuts the pleural space, and there was no evidence of pleural effusion within those exam limits. Clinical follow-up was recommended after the Prenuvo scan, and a CT thorax and subsequent biopsy were completed. This patient was unfortunately diagnosed as having small cell carcinoma of the left upper lobe. Thankfully, this patient was quickly evaluated by MD Anderson in Houston, where he underwent partial lobectomy, subsequent short rounds of chemo and radiation. I'm happy to say this patient is now 6 months post-op, recovering well. He was a smoker. I didn't mention that earlier. 30-pack year history, has quit smoking per his spouse's recent updates. She was very proud to say, and is able to maintain his pulmonary health. He's able to walk and exercise and spend more time with his family. Really just one of the outcomes that we're the most proud of is cases like this, where we were contributing to an existing modality that this patient perhaps should have gotten a low-dose CT. I don't believe he ever had, but he found himself into a Prenuvo scan, and we were able to help catch what that scan didn't. The next couple of diseases are really important because they do not have any standard screening guidelines. And so this is really the space that Prenuvo lives in. Ovarian cancer is first up. As you can see from this chart, ovarian cancer is the 5th leading cause of cancer deaths in the US, but it carries a grade D recommendation for screening by the USPSTF. And that's because of the historically invasive and poor quality imaging required to visualize an adnexal malignancy. So it's really just this brutal statistic that nearly 20,000 women will be diagnosed with ovarian cancer in just this year alone. over half of those women will end up passing away from that cancer because of these relatively late stage diagnoses of detection. Some more statistics to throw at you. We're able to see now that there's an overall dismal 30% survival rate for all ovarian cancers compared to 91% for breast cancer. And only 1/5 of all ovarian cancer cases are detected in early stages. And that's again because of the lack of early screening options. You compare that to the 10% of women who survive for 5 years when their cancer is diagnosed in late stages 3 to 4, there's a 95% survival when diagnosed in stages 1 or 2. So again, this is one of those really critical conditions. If we can catch it early, we have a 95% likelihood of survival, but most of the cases we're not doing that. Prenuvo is helping. Adnexal mass characterization on the non-contrast MRI you're looking at has a high accuracy and excellent inter and intra-reader agreement. So this is all a bunch of words saying essentially that non-contrast MRI is reproducible, it is reliable. That the non-contrast score value greater than 4 was associated with malignancy with a sensitivity of 84.9%, a specificity of 95.9%. That's an accuracy of 94.2%. So whole body MRI in this 2021 European study was excellent at detecting ovarian cancers. Here is the proof. This is a real Prenuvo patient, a 45-year-old asymptomatic female with a suspicious right ovarian cystic lesion. The patient had 2 children and was a longtime smoker. The patient underwent their scan. We discovered the cystic lesion, recommended the follow-up appropriately, and it ultimately was confirmed as serous ovarian carcinoma, stage 2. The patient underwent surgical oophorectomy without any further treatment, no chemo, no radiation, and essentially was given a complete cure of disease prognosis. So this was one of those miraculous cases where the ovarian cancer was not allowed to progress to stage 3 or 4, and the survival of this patient is now very much intact. Getting close to these last couple of conditions, I love to talk about liver cancer because, again, it's another one of these conditions that has no screening guidelines, but it's something that Prenuvo and whole body MRI is excellent at detecting. Why screen for the liver? Well, liver cancers are now the 6th most common cause of cancer-related deaths in the U.S. Those case numbers have tripled since 1980, by the way, and it should be no surprise why, but we'll get into that. The death rate from liver cancer in the U.S. has increased by more than 40% in just the last 2 decades. And while therapies and the survival rate for other types of cancers have dramatically improved over the past few decades, liver cancer prognosis remains unfavorable and deadly. It's just not a field that we're making huge strides in. Now, in particular, the cancers to know about with the liver are hepatocellular carcinoma, which is somewhere in the 80-90% incidence. And then you have your cholangiocarcinoma, neuroendocrine tumors, and hepatic adenomas, which are a small fraction. So really, we need to focus on the hepatocellular carcinomas if we're looking for a sort of majority approach here. The liver cancer screening indications are if you are an adult at high risk because you have an increased chance of disease, there's currently no screening recommended for adults at average risk. Increased risk doesn't mean liver cancer is certain, but it should lead to regular screening exams to detect a cancer in the early stage. So again, early detection is the key. When we look at diffusion-weighted imaging, the DWI sequence from our MRI scans compared to other screening tests, really just look at these numbers. The DWI sensitivity was 83%, false positive rate was only 2. Now, when you compare that to ultrasound, which has a 100% sensitivity rate, there's still a 10% false positive rate. So the majority advantage of a DWI MRI over your ultrasound screening is that there's been a low false positive rate on the MRI. That's a very important piece when it comes to screening, is low false positives. We need to make sure that when we call something, we are correct about it, that we're not putting the patient through unnecessary biopsies and harm. That number gets augmented when you add AFP serum testing. So that's another piece of the puzzle that needs to come into play here. Look at the benefits of an MRI using the diffusion-weighted sequence. When attempting to detect liver cancer, MRI without contrast using DWI has been shown to have comparable detection rates with ultrasound and superior detection rate to that of an AFP on its own. But when you actually add those things together, you're getting a significantly higher sensitivity and specificity. So that is going to be maybe the next stage of these guidelines will come out, and we will actually see a recommendation for DWI plus AFP testing. Here we have a quick picture of a patient from Prenuvo. This DWI sequence detected the gray area here, which represents a malignant hepatic tissue. This was an otherwise asymptomatic patient who was able to undergo liver resection and preserve their life, preserve the remaining hepatic function. And again, this was something that was detected through Prenuvo, not through labs, not through the patient's routine blood work, which showed totally normal transaminases. The last condition I want to spend some time on is pancreatic cancer, a really difficult subject. A recent ACS yearly study showed that cancer mortality is dropping, but incidence in women is higher, and there's a lack of progress in pancreatic cancer. I mean, this is just a condition that has had no real movement for a number of years now. So this again highlights the need for a different type of screening service. Here we're going to look at a 44-year-old female who completed their whole body MRI, who had a recent diagnosis of type 1 diabetes, but no imaging. There's no standard recommendation for imaging of the pancreas with type 1 diabetes, and so there it is. So while no imaging was originally ordered by her endocrinologist, Prenuvo, the patient came and self-scheduled their exam with us, and we observed a hyperintense signal in the distal pancreas. This was diagnosed as hypercellular pancreatic neoplasm, and that, like our liver patient, was able to undergo pancreatectomy, distal pancreatectomy, 6 months of chemo without causing any permanent damage. This patient recently celebrated the 1-year history of remission for this disease, which otherwise typically a 1-year survival rate is somewhere in the 20 to 15% neighborhood. 5-year survival, 12%. So this is a patient who has beat the odds by detecting this cancer early, had the symptom of type 1 diabetes at 44 years old, but no standard of care recommendation was given because it just doesn't exist. And that's, again, where something like a whole body MRI is going to really enhance your practice, enhance your patient's experience, because we may catch what the standards have not. So I wanted to give just a brief summary here. We are looking at the future of preventative medicine. And, the future of preventative medicine really lives in technology at this point. I wanted to bring this to everyone's attention that there's a recent article that discussed the idea of cell-free DNA sequencing. So in addition to whole body MRI, we can start to think about things like liquid biopsies or the multi-cancer early detection tests, cell-free DNA sequencing. This article in particular combines two of those modalities in a very novel method that has not yet been studied. So this population, the pretest probability of cancers was screened using cell-free DNA. When someone triggered a positive cell-free DNA test, this was in a prenatal or a maternal setting, then they were verified using whole body MRI. In this study, cancer ended up being present in 52 of the 107 participants. That's a 48.6 true positive rate. The sensitivity and specificity of the whole body MRI in detecting that cancer when used ended up being 98% and then 88% respectively. So 98% sensitivity, 88.5 specificity. We were able to really ratchet up the detection of these cancers when we had that pre-test probability with the cell-free DNA. That to me is the future of healthcare. By using a combination of all these new technologies, we're going to really greatly enhance our ability to detect and get ahead and diagnose early these cancers. So I want to sort of wrap up here into the bigger picture, I guess, on a population level of why screening is so important. Think about breast, cervical, colorectal, lung, and prostate cancer. Right now, we're looking at 4.75 million cases of these things are affecting our country right now annually, and that's really just a number that we have got to figure out how to we're supporting this in the healthcare system. We're trying to figure out how to cut back on this number, and so the idea of prevention and screening, we have to get more accountable. And the quote on the side I really love, it says, although many people may believe that treatment advances are the major driver of reductions in mortality, the surprise here is how much prevention and screening contribute to the reductions in mortality. So, that's Katrina Goddard, who was a director of the NCI. The last slide here touches a little bit on the economics of this disease state, that preventative proactive healthcare could potentially decrease overall cost to patients as well as the healthcare system. In the context of cancer, the economics of early diagnosis and interventions can be huge. The U.S. is spending over $150 billion a year on cancer treatments alone, the majority of which is spent on hospitalizations and cancer drugs. Most cancers caught at an early stage do not require costly hospitalizations or systemic cancer drugs, and can even rely on lifestyle modifications in addition to more cost-effective treatment plans. So, this is one of the single largest drivers of healthcare expenses in our country. And, we have to kind of come back to the table and discuss whether the expense of a whole body MRI up front outweighs or adds to the long-term costs in this country for sick care. Thank everyone very much and have a great, safe day.